Good morning or good afternoon, depending on where you are, and welcome to the webinar, A New Normal with New Outcomes, Managing Risk and Activating Healthcare to Thrive in 2020. I'm Dr. David Nash, Chief Medical Officer here at Innovaccer, and I am very pleased to welcome you all as guests for joining our webinar and would like to get started. So with no further ado, let me introduce our two panelists. First off, we have Dr. David Nash, founding Dean Emeritus at Jefferson College of Population Health and a very good friend for many years. David, welcome for joining.
Thanks, great to be here.
Awesome. And then also Jason Krupp, president of the Central Maine Medical Group, who will tell us a little bit about what they've been doing in Central Maine, and also, I think, a graduate of the residency program at Jefferson. So there's a nice tie-in here. Jason, welcome.
Thank you very much. Yes, Dr. Nash presented me with the MedStaff Office Documentation Award. I'm that guy.
He was a great house officer. There you go. It just means I've been around for too long, David Nace. That's all.
Well, you and I, we have that in common.
Indeed.
Awesome. Well, this is going to be a great panel, and it's super and great timing to have this discussion. So welcome both of you. So we've talked about a pandemic now for almost 4 months. And many of us are thinking about, geez, all the changes we've had to do in just to adapt to COVID-19, to think about the safety of our patients, ourselves, and having the impact that it's had on us. And also thinking about what is this going to mean going forward? What is the new normal? So David, let me start off with you. I know your experience at Jefferson is that, you got hit pretty significantly by this pandemic.
Yes, well, first of all, thanks again for having me on, and Jason, great to have you be a part of the conversation, and thanks to everybody for carving out time in their busy day. I want to give a great shout out to my Jefferson colleagues, most especially Dr. Bruce Meyer and Dr. John Gleason. These were the folks who led our effort across 14 hospitals. I think, David Nace, the thing that Bruce and John concentrated on first was safety for our team, safety for the clinicians, everybody at the bedside. We had a less than 1% infection rate for all clinicians caring for COVID patients during the surge in April and May especially. And I think the safety of the team was a critical factor in making the patients safer as well. So we had the right staff at the right place at the right time. I don't think we had nearly the number of cases like in New York, but enough that we had to close the entire place, open up more ICU beds, all of the things you read about in the news. But to me, the real valor was the safety, the commitment to safety of the team first and the patients second. And that worked really, really well. And I'm sure they'll write all about that in the near future, but it was an incredible effort by everybody. I think I'm way too old to be at the bedside anymore, especially fighting something so dreadful and complicated and new as COVID-19. But the teamwork that was necessary, the incident command structure, the daily huddle, the closure of the feedback loop, the acceptance of daily updates and guidelines. I mean, I think there are the tenets of high reliability and performance improvement were visible every day. And I think that's another take-home message as to how successful the clinicians at Jefferson were by adopting and embracing those tenets.
And Jason, I know you've had a similar experience there in Maine, a very different environment, less urban, more rural, and you've had to adopt some new technologies to deal with your situation as well.
Yeah, we, already state of Maine's a very rural state, and actually not very accepting of some of the new technologies over the in the past, very traditional with regards to healthcare. And so with the onset of COVID and, the shutting down of offices and services and sheltering in place, a number of patients, and I know this isn't just for my group, Central Maine Medical Group, but this was with a lot of the other health systems in the state, really didn't have very advanced technological capabilities to connect with the patients, nor were the patients necessarily prepared to accept it. So necessity is the mother of all invention on some level. And with working with Innovaccer, as we'll talk about, I think a little bit later on, we really built something from nothing, and with really good experience. And just personally, you know, as we talk about the new normal, you know, there's some piece of the new normal that I don't want to change, because I think it's been a positive thing on some level with regards to connecting with our patients.
Well, I think one of the things that certainly I would like to think about eventually bringing an end to is the use of face masks, but we can all hope and dream about that.
Right. Well, you know, I think Atul Gawande, who most folks know by now, you know, and he's got a wonderful perspective on this. I'll just share it. So if 60% of Americans wore a mask that was 60% effective, in other words, not a bandana, we would lick COVID, no problem. We'd crush it. So, you know, along with herd immunity, but the best vaccine we got is a face mask. That's really the key. And there you go.
I would ask it that, yeah.
Although that looked like a Dallas Cowboys face mask, so that's the wrong thing to show to a Philly guy. But in all seriousness, 60% of people wearing a 60% effective mask most of the time, and we wouldn't be having this conversation. How easy is that? I mean, beyond belief. So lack of leadership, that's all this really is.
Yeah, I think leadership is so important. And there's an important point on this slide here. David, you and I have recently talked about Payriders, and I think that's a nice capture for one organizational structure about providers and payers needing to work together or integrate.
Well, I think David Nace, especially, we've seen in you know, yesterday's news, United Healthcare hitting an all-time record cash supply, and you know, I can't speak for every firm, but look, it is clear that the for-profit managed care industry had very low expenses and drove down their MLR further than ever, because no procedures, no hospitalizations, no ER visits by members. I think that's one factor that's contributing to what you and I have talked about previously, the evolution of new relationships between for-profit payers and provider organizations. And I'm confident that these new structures, joint ventures, subsidiaries, and the like, we've coined this corny term, the Payrider. You know, it's awkward for sure, but I do think it symbolizes where we believe the market is heading in part, and that is these new relationships that didn't exist before. Look, the road to risk is the road we've got to be on, right? I think most folks would agree with that today. And the road to risk is paved with these new relationships, because most provider organizations, most especially on the East Coast, don't know much about bearing economic risk for clinical decision making. Whereas lots of providers on the West Coast, this is all that they know. Yep. So my predictions, worth about 4 cents, is the rise of the Payrider.
Well, you know, it's interesting, even just from from that financial standpoint, one of my concerns, again, from the new normal, is one of the ways in which we've been able to leverage the televideo and telehealth, just from a business standpoint, is that our payers have created these waivers where they're paying us as though it were, I'll say, a real visit, which right. I think it is. And you know, I think in some parts of the country, I think it's very much a state-by-state, payer-by-payer issue. Those waivers may be coming to an end.
And I regret right. So, you know, we've had more social change in 120 days than in the previous, you know, decade. And as you noted, of course, so look, to withdraw or reduce payment now, boys, that's knuckleheaded for sure, right? I mean, we've found a whole new way, and I have two observations on this. One, I'll attribute to Dr. Steve Pasco at Jefferson, our leader. who talks about why do we call it telehealth? We don't call it telebanking, you know. So I think virtual health is probably a better term, but this is the new normal. I think for all kinds of good reasons. Tom Lee, who a lot of folks know, of course, Press Ganey, Harvard Medical School, he's reflected with me that he's been active doing telehealth visits as a primary care doctor, and he's seen his number and type of tests go down. You know, so I think there's another silver lining. Maybe we'll get to it later about reduced. Maybe I would call it delivering high value virtual health.
That's right.
Jason, I know you've thought about moving into sort of this new world at Central Maine of accountable care and, you know, delivering and taking on more, not just upside, perhaps downside risk, and the idea of creating efficiency, not just using things like telehealth and virtual care technologies, but also automating and giving people what we often call here activated intelligence within their workflow.
Yep. Yeah, you know, David, to your point, I mean, I spent a decent amount of time as a chief medical officer with Banner out west, very big in population health and value-based care. You know, here in Maine, that those market forces hadn't in the past really pushed on this part of the country. So the organization that I'm part of now, Central Maine Healthcare, we're very focused. Our CEO comes from Centara out west. We're very focused on growing our value-based approach to care and really differentiating ourselves in the market with that. In my experience going through the past, 10 years, being successful in value-based care and population health is really a function. If you consider quality care being table stakes, you've got competent people providing the care. Being successful is really a function of the right data and good operations. And when I say operations, I mean access. I mean the right people in the office, the right connection to the patients themselves. And we're building that here at Central Maine Healthcare with Innovaccer. So I'm really excited that it's starting to go online, because as we look at gaps in care for our providers, as we look at, hey, where are patients actually going to get their care from a cost standpoint, on some level we're flying blind without the sort of data that Innovaccer provides us. So, this is exciting for us. I know our physicians, our providers are really excited, because as all three of us know, and I'm sure many on the phone know, we're there. Our mindset is right. We need the information. We need the information in order to be able to steer and drive our practices. So it's an exciting time for us.
And the bottom line is really about how do we engage patients, right, to get better outcomes. And so changing the patient experience seems to be another piece of this. David, isn't that your experience?
Oh, for sure. So look, I'll put it into the language of population health. You can't improve the health of a population unless the population's engaged in the process with us. And I think historically we didn't really think in those terms, right? And boy, the pandemic has shined a very bright light on, among other things, those pesky social determinants. How do we engage with patients? How do we close the feedback loop? If virtual health is one way of engaging with patients, great, I'm all for it, for sure. But I think there's more to it. Clearly, you got to have the access, you got to have the convenience, it better be a good experience. And then maybe later we'll talk about how do we measure the outcome, right? So we've got literally thousands of new clinicians who are new to delivering virtual health services. And I'm ambivalent about that. On the one hand, great, because we have an army of providers and giving patients access and so on. And then there's another part of me over here that says, okay, who's doing what? And what are the outcomes of these interactions? But the punchline is you can't improve the health of a population unless they're engaged in the process with you. Wow, it seems pretty straightforward, but it ain't.
That's the big risk for anybody getting into this field. Is that's the big X factor for you can be a wonderful health system and have great operations, but if the population isn't interested, you haven't connected with them.
Right.
some
Right.
meaningful level, it doesn't matter what I want at the end of the day.
And constantly working to reduce the barriers to entry, getting this into communities that don't have internet access and don't own an iPad or an iPhone, as an example. I mean, this is complicated. We also, in my outside work, talking to many companies, there are folks tracking the difference between traction in the minority community versus non-minority community. It's very interesting. And that's one area. Second area is who's delivering the advice, what are the outcome measures? I mean, there's a lot of fertile opportunity here to explore this in much more detail.
Yeah, it's interesting. We have a community here in Lewiston. It's called the New Mainer community. A number of from a number of patients from Africa, Somalia, and in this whole COVID testing, tracking, trying to reach out and stay connected with the healthcare system. That was a big challenge for us. I think we were very proactive with it. We actually went out to the community to try and connect, as opposed to waiting for them to come to us. And I think we had a good experience with that.
Sounds like there's a number of different ways to really enhance the patient experience, to enhance collaboration. Can technology be a piece of that equation? Can that be part of the solution?
Well, I think our listeners would say, sure. I think another aspect we haven't touched on is our hope that as the marginal cost of the technology comes down, we might be stimulated to reach out to populations who we haven't previously really spent a lot of time with. And in the more recent conversation about racial justice, I mean, you could make a case that we need to reach out to populations that we haven't previously connected to. And if the marginal cost does really go down, which I believe it will, that's a net positive. But that's not going to fix, the racial divide anytime soon. But it is a step in the right direction for sure. Reaching out to populations who don't feel that they have connectivity to us. I think there are risks here, though, David Nace. If we don't have the right data, if we don't have systems for follow-up, if we're not resilient in having a process that sort of makes sense, is flexible, learning, adaptable. I mean, a slam bam, one visit and no follow-up and how are you doing, that's not going to work. So getting on the bandwagon, if you would, for virtual health, that's just a baby step. Making sure we do all these other things, shared decision-making, availability, education. What about health literacy? And what about having a doctor who looks like you talking to you? We're not going to fix that tomorrow.
So it's so important, David, I think, as you've often talked with me before, about addressing these social determinants of health. Yeah. What is somebody's environment, their economics, their barriers to care?
Well, gosh, those pesky social determinants now seem pretty darn important, don't they? And I know folks are tired of hearing me say it, but I'm going to say it again. 10 years ago, more than 10 years ago, when we opened the doors to what was the nation's first college of population health at Jefferson, and we talked about the social determinants, which of course we did not invent, but David Kindig was talking about this in 2003. All of a sudden now those social determinants, it's front page news, right? Because the minority community got slammed by COVID because it shined a bright light on what we all know, that they were less healthy, in part because they were poor. And the social determinants, the key thing is a zip code and credit score. Way more important for me to know that than, your blood pressure is interesting. But let me tell you something, it's your zip code and credit score that I really need to know to help me define your life expectancy. How crazy is that? And then you graft it on top of the politics of this map. If I live in a red state and I'm a Medicaid recipient, I'm going to be less healthy than if I live in a blue state. Well, the rest of the world looks at this and wonders we've lost our mind, as it relates to connecting healthcare to the social determinants and politics. So Look, we got a lot of work to do. If virtual health can reduce disparities, fantastic, bring it on. If technology can do remote monitoring in communities that we haven't previously connected with, great, let's do it. But the blocking and tackling of transportation, care coordination, food, education, reducing crime, all of that is still really, really important. And I can say that because I've lived and worked in Philadelphia now for 40 years, and we're the nation's poorest city of the top 10 cities by population, right? So we got 1 out of 4 people living in poverty. That's what drives poor health. That's the first, second, and third reason. So in America, if you're poor, you're in a terrible spot as it relates to access, coverage, and health.
Well, as you know, one of the advances we've made here at Innovaccer is developing a machine learned and artificial intelligence view of looking at multiple data sources to create a vulnerability index and thus facilitate what we call a closed loop referral. And we all know this on this panel. When we refer to specialists, we want to be able to send the information they need, make sure the patient gets their appointment, make sure we get their consultative feedback. But have we done that with community resources? Let's take a quick check-in with our audience to see, have you all been able to make closed loop referrals to your community resources? So 4 options, just go into the chat box and select one of the following questions. Contact your patient to see if patients were provided, maybe verify directly with the community resource, use some form of technology such as we use here at Innovaccer for the automatic closed loop referral, or you're just not able to close the loop. You can give somebody a reference, but you don't know what happens. So while we wait for that answer, Jason, what's been your experience in Maine around using community-based resources, making referrals, making sure those referrals provide needed resources, close gaps, close barriers to socioeconomic and environmental issues?
It's been difficult for us. I mean, we have, Maine is underserved as it relates to those sorts of community resources, even from a provider standpoint. But all we have from an information standpoint is, hey, we put the referral in. But actually knowing that somebody went to it, that's almost an open end for us right now, and it's challenging because again, these community resources tend to help us in dealing with those social determinants of health, which are so impactful. So we Lewiston, which is where we're headquartered, is a very working class city with a good deal of poverty, and it's been challenging. And I think if we want to succeed in this area, we're going to have to tighten up with our systems, and then obviously from our information systems as well, to be able to track and be able to use the resources. The key is that you have this data, you know where to focus on. You can see where the gaps are and use what's becoming an increasingly limited amount of resources to focus it in the most impactful way. So it's been challenging for us.
Great. Well, let's check in with our audience to see what their experience are. I think the poll is about ready to close. Yes, here we go. This is interesting. Responses all over the place.
Wow.
David?
Yeah. So David Nace, wow. So a quarter of all the respondents can't close the loop. That's not a surprise. I don't think we're wired quite yet to do that. So that's really pretty remarkable. But okay, a third somehow do contact the patient, which is great.
And it's great to be seeing people use technology for electronic referral and closure. That's awesome.
Yep.
Well, let's go back to the one area where we have seen good adoption, particularly with this pandemic. And that's that providers, we've all been using telehealth and turning to telehealth to address this issue. David, you brought up before that we've kind of jumped ahead very quickly.
Yes. So again, I'm so proud of our team at Jefferson. We had a 5-year head start, had 8 faculty members already committed full time to telehealth, and so we were ready to train nearly 1,000 clinicians to do telehealth. So that, again, I think this was a nice to have 5 years ago. Now it's you got to have it. But as Jason noted, if CMS and others decide, well, we're going to pull back on the payment, I'm afraid that infrastructure we created is going to, rust away, that no one's going to use it if we can't get paid. I see it from a different view, that this is all interconnected, that mobile health and virtual health, anything that we could do to, shut the faucet instead of constantly mopping up the floor, if virtual health is a tool to get us to that place, then that's fantastic. If it's a one-off and we only did it because, all elective surgery was shut down for 3 months, then it's not going to get us anywhere. I'm confident that provider organizations that get it, like where Jason is, where I am, they're going to use these tools in a much broader context. I sure hope so.
So there's been a
I have to throw this out there that one of the dynamics with all of this that allowed, I think, some of this jump ahead, because obviously it takes patience to adopt it, but as we all know, physicians aren't the most change. They don't love change so much. It's a difficult group to move along, and frankly, that's some of my job. This is the first time that I can remember in my career that physicians' own compensation and their own financial standing, and it has been threatened to the extent that it was with the shutdown of services. And I'd be lying if I didn't say that it opened up a lot of our providers saying, geez, we better find a way to adapt and change quickly to be able not only to meet the needs of their patients, but also to sustain their business. And that was helpful in that regard.
Well, Jason, I think, clearly around the country, lots of our peers, relied on telemedicine as a really important source of income replacement. Economically, there is no question that this is true. My worry is, well, if that's all we view it as,
no doubt,
shame on us. So unless it's about delivering health and not just health care, then it's all for naught. So I've been dealing, as all leaders have, I think, with some challenges among our peers. There's a large group who, let's get back and, kickstart the utilization engine. And that will be fine. Well, we won't be. So, I think, again, the beauty of some of the Innovaccer tools here is, look, let's continue to look at the gaps in care, close those gaps. Let's reduce waste. Let's produce high value. That's what we've got to continue on the road. If we take a detour and it's all about, let's get back in the office and do what we were doing before, well, that's not going to work. Let's put it this way. And David, I wish we could ask our listeners, raise your hand if you think that the system that brought us to the edge of the abyss is the system that's going to take us into the future. I can't sleep thinking about this. How can it be? Right? That's my view. So as it relates to virtual health, if it's just to kickstart the engine, I don't want anything to do with it. If we're all about health, bring it on.
Yeah, Jason, we, and David knows this, Mike Levitt talked to a group interested in accountable care just as the pandemic was starting. And as you know, when he was HHS director, he dealt with an earlier near pandemic. And, one of the things he warned us about was exactly what David mentioned. We've had a leap forward around the use of technologies in virtual care and other ways of thinking about the community. We can either use that to catapult forward, or we could backtrack, like many folks will do, in order to save and recoup financing by going back to high profitable service line delivery.
But the trick is, where the rubber meets the road, which is, systems like my own here in Maine, we need to find a way to combine what you're describing, which is delivering health, making sure the payers get aligned, because what the real scare here is, and the government has stepped in with millions of dollars of grants and funding so that our systems can continue to exist to provide the underserved care. So I'm Banner trained. I'm 100% value-based care. I just from a reality standpoint, we've got to find that balance. We work really closely with our payers, with Anthem, and obviously we're working with the governor, to align incentives. I want all of my primary care and my specialty care physicians, providers, preserving health, absolutely. But you know as well as I do that if you said it yourself, that if the government backtracks on being able to pay for the services, then how does a business continue to provide the services? So it's a real conundrum, and I think the groundswell change that you're describing, which I am 100% behind, it's going to take a lot of alignment, a lot of rowing in the same direction nationally to get to where we want to get to.
What's really interesting, we're getting a lot of comments in the question bar around both applauding our mentioning social determinants of health, as well as a lot of questions about will rural areas be able to adopt technology? Jason, you're going to talk about that in a second. But mostly, how do we really think about this use of telehealth in improving community resilience as we move forward? How do we keep this from being the conundrum that we've run into this time? David?
Yeah, well, this is a great diagram, and even introducing the term, resilience as it relates to virtual health. I mean, this is really clever, smart, catchy, and maybe even enduring and compelling. Right? Look, we're not out of the woods by any stretch. We got 45 states that are seeing an increase in cases, including Pennsylvania and my own county, right? So anybody who thinks that, we beat this virus, they know better. So we're going to need new ways to connect with patients, keep communities resilient, get them to tackle chronic illness, maintain health, get that mammogram, get the colonoscopy, get the hemoglobin A1C, get the eye exam, the stuff that we know is high value. So if it could contribute to delivering high value and keep communities connected and resilient, fantastic. I'm all for it. And it's going to take some extra steps, like, the Innovaccer tool where you can measure the severity, right, of the social determinant issues. That's really important. So then we'll tie that into Epic or Cerner. And if it's one-stop shopping for the providers on the same screen, and then you can say, well, wait a minute, I see you're from zip code, 12345. Wow, we know that's a difficult zip code to live in. How did you get here today? Do you have transportation? Is there food in your refrigerator? Can you afford your meds? We could have a different conversation. And I think that's community support, social care, and all the rest. But, as Jason knows from his operational experience, this is culture change for docs. For my generation, forget about it. Not going to happen. But for Jason's generation, for my daughter's generation practicing, they get this. For old guys like Nash and Nash, forget it. But young guys and gals, there's hope. There's real hope.
It'd be interesting. What would a score for community resiliency? What would that look like, and what components of what you described would be a part of that?
Whoa! You see why he won this prize years ago? I mean, the guys.
There you go. It's funny. One of the folks on our audience brought up the idea about being community resource referrals being so important. The idea of a community transition coach whose primary role is to reduce a preventable readmission by being the bridge for the patient to their community resource.
So I want to comment about that. Great that you could get feedback like that so quickly. So look, we're tracking, let me back up. So, Rita Numeroff and her eponymous company and I have been working for 5 years. We've documented the rise of the chief population health officer. I mean, we didn't invent this, we just documented it. And now we're seeing yet another inflection point, David Nace. Companies and provider organizations are moving just to the chief health officer. I mean, the irony to some extent, but okay, put that aside. But the C-suite occupant charged with doing what you just described, right? Are we connecting? Are we making a difference in the community? Wow. And under this person might even be other areas of responsibility, diversity, right? Community engagement, reducing disparities. Oh, and by the way, improving health while we're doing all of this, right? I mean, so very cool. Maybe we do need somebody in the C-suite who always raises her hand and says, wait a minute, what's the community connectivity here that we're going to promote, right?
And there's another piece, just using virtual technologies in general. I have another comment from the audience that mentions certain subspecialties, and I'll edit this in my own editorial license, believe they are dependent upon having face-to-face visits or at least diagnostic testing.
Yeah, I get it. Sure.
Yeah. And
it's hard to put in a stent virtually,
Yeah, right.
I get it.
So on the question of testing, though, the idea of mobile diagnostics was brought up by this person in the audience. That's a great concept.
Mobile diagnostics. Okay, so let's get Jason and me. We're going to push a little bit on this. What about just calling it remote care?
Right.
And let's get remote care all the way. How about acute care remotely? Like, why not? We medically home, big company, right? Mayo Clinic's involved. Let's just keep everybody home. I mean, up to the point that we could do that, but we have the technology, right? So let's deliver care wherever the patients are.
Well, we've been talking about a hospital without walls for many years, right? And as the technology has caught up now, and even, I don't know, as 5G comes out and improves, the real-time capabilities from being remote, I think there's huge opportunity. We know we can do it. I think the interesting challenge for me behind that is to your point, David, is I don't want to get to a place where we're just utilizing it because we can do it, right? And I worry sometimes with our technology.
Yeah, I'm sorry to interrupt you, but or we're just doing it because we're getting paid to do it.
Yeah,
right.
Exactly.
Well, regardless, there are some reasons that you need to come and visit the facility. As David said, it's hard to put a stent in, and patients are concerned about their safety when coming back. I, for one, have a dental appointment next week, and I'm debating whether or not I should cancel or not. So maybe we could say a little bit about this. And Jason, I know you've thought about this, leveraging telehealth. What are your thoughts?
So let me tackle this first again, and I'm going to give great credit to Doctors Meyer and Gleason, who have spent days thinking through with our leadership team how to create a safe return environment, right? Like all big places, we've struggled with this, and the front line. So you're going to have the plexiglass and the face shields and the mandatory masks and mandatory hand washing, and we're going to empty out the waiting room, and you'll wait in the parking lot, and all the rest. But the data that we've reviewed, and I just did a deep dive on this for our journal, Population Health Management. David Nace, the numbers are all over the place. When you add these national surveys, somewhere between a third to half of all patients say, I'm not going back. So we don't know, where this falls out is going to be pretty damn important. But the latest numbers that I have seen, fully a third to a half, depending on where you are and the age group, even folks with chronic illness who need to be seen periodically, they're petrified, and who could blame them?
So in order for us to be successful in these goals that we have to provide value care, we've got to meet patients where they're at, right? So when I sit there and I talk, I had this great chief operating officer when I was with CHI Health Clinics in Omaha, and he used to talk about call, click, or come on in, right? I mean, so now as what we've done in our clinics is, you know, we've just given everybody the option. We say, listen, if you need to come in, it's safe. We had our doctors reach out to patients with that message. Here's all the things that you described with, you know, the mask, all that stuff. If you want a telehealth visit, we've got it. You know, we will meet you where you're at, so that those chronic diseases that have been, I mean, it's interesting. I don't know if this was national, but what we experienced here at CMH was like the number of heart attacks in the emergency department dropped precipitously.
Yeah. Well,
having heart attacks?
Followed that. So Jason, you know, we looked at that in Philly, and regrettably, we have data unpublished, but we have data from the public health department. We had a lot of dead on arrival at home, and we had strokes at home, MI at home. You know, John Gleason, Steve Glasgow called this the the pandemic that didn't happen because they couldn't get to us. But, you know, one way to think about it. But I think if we could go back one slide before we talk about Central Maine. So I have one real worry, and that is the flu season in the fall. We got to get people the flu vaccine, right? Otherwise, we're going to have a double whammy, especially with the elderly. So the visit, so here's the question, which we can't answer today, but would be great to come back to. What's the visit going to look like to get the flu vaccine as widely disseminated as possible, right? So that's a parking lot, the Rite Aid, Walgreens, I don't care where it is, right? So we're going to need to really work hard to get the vaccination rate in the flu season. And let's hope we get the right vaccine and we pick the right combination, et cetera, et cetera. But we got to really start thinking now about making sure we get the flu vaccine out the door to the right people at the right time.
And I think you brought up the point already. We've had this discussion about, is it always about, in a fee-for-service world, you need to come to my office?
Well, right.
I think, can we come to you or meet you in your community? And I think that's just such a key point. So let's use this opportunity, I think, Jason. Not everybody is that familiar with Central Maine, and you have a great story for a more rural community in terms of some of the things that you've done to address this pandemic. Walk us through this.
Yeah, thanks. So Central Maine Healthcare, we are located somewhere between Augusta and Portland. We reach up to Augusta and out to the Atlantic Ocean, the Mid-Coast area, Bath, Brunswick. We're a tertiary care center, level 2 trauma center. We have 2 critical access hospitals, about 30 to 40 clinics, a couple of urgent care sites, and an ambulatory surgery center. Maine, for those of you that don't know, is the oldest state in the country. We've got about 1.3 million people, and it's not growing. And frankly, it's pretty difficult to recruit to Maine. Most of the people that we, from a provider standpoint, that we get here have some previous connection to Maine. You know, although it's been different as people head out of New York City and Boston and come up to the country to get away from some of the disease centers. It's, you know, we have to provide care to an aging population with a pretty thin provider group, and they're great providers. One of the reasons that I wanted to come here is because you know, Maine's also one of the most expensive states in the country to provide care for. You know, everything's hospital-based billing. I told you it hasn't been really on the forefront of accountable care, value-based care. It's been very fee-for-service, very traditional. And Jeff Brickman, our CEO, comes, you know, and wanted to really disrupt the state. And so it's kind of an exciting time to be here and kind of go through that transition that I believe in very much. So if we go to the next slide, one of the things that I wanted to show was this was an example of our telehealth, both televideo and telephone visits. If you go to the lower right there and look at the dark blue bars, that increase is basically us coming together with Innovaccer, starting from scratch, starting from zero. It just wasn't. We've had telehealth up here for years with our employee benefits, and the usage was zero. So really starting with Innovaccer from scratch and growing, both with phone and video visits. And then as you get to the next slide and this whole concept of resiliency, of community resiliency, I don't know what the proxy is for it. I don't know what that number is, but this is just our patient experience scores, which you can see were pretty stable for a number of months. And then that same point, March and April, where we started working with Innovaccer and the pandemic hit, and all of a sudden access meant something totally different. Patients loved it. They felt comfortable. They were happy getting their care that way. And actually, as the payers aligned with us to be able to provide that level of care, you call this a success. At some point, we were over 14,000 telephone visits in the month of April, but not just telephone and televideo. And we all know that when patient experience is higher, you tend to align that with compliance. You tend to align that with following through on what needs to be done. So, I think some of the challenges that we run into in a rural state, and David Nash, you mentioned this earlier, is that of the places that we weren't able to really connect with in our system, really out by the critical access hospitals, mostly in Rumford and Bridgeton, mostly it was because our patients didn't have internet. They simply didn't have it. So we could sit there and want to reach out, but given the nature of a rural state or a poorer state, we just didn't have the capability electronically to connect.
And these are great points. Interestingly, we've had a number of questions come in on this matter. Both of you know that the name Innovaccer we're a data platform company. We're not a telehealth company per se. We're not a population health company. We're not a data warehouse company. We're not a payer FHIR-based API company. We are all of those things. That's the innovation of having a data platform, sort of a new disruptive technology. And so, this allowed us to be able to help Central Maine pivot on a dime and innovate to find a telehealth solution when they needed it, or some other solution. Obviously, Jason, as you know, we originally started thinking about population health and
absolutely.
So the question in the audience is, innovative and disruptive technologies require some degree of investment. How do you convince the organization that there's an ROI, a return on investment, in adopting when these are innovative and aren't sure?
You go first, Jason. You're a
well,
solid.
I'm gonna put a plug in because this was, we were scrambling, scratching our head of what are we gonna do? Like a lot of systems, this is something we've never dealt with. Actually, one of the reasons that we, because we've been working with Innovaccer from a platform standpoint for population health, but to be frank, Innovaccer was a real partner there and came to us and said, here, use this. We're working on this televideo. Use it, we'll help you. And that was huge. That was a real great example of partnership between a company and a health system. I think at the end of the day, and you're going to hate this, David Nash, but I'm just here at the ground level. You have to hire the providers to be able to provide the care. The providers need to get paid. The pay needs to come from somewhere, which then induces the systems to say, hey, listen, this has to make financial sense. Otherwise, it's difficult to move forward. I don't think that the technical capabilities are that advanced, are that cumbersome to get past. I think it's more the system and the payer structure which makes it difficult.
Well, I would agree with that. Yeah. And we talked about this earlier that, if it's just back to business because we're getting paid, it doesn't really make much sense.
Right.
But I'm happy to see the patient experience is positive. That's great.
It's a good thing.
Let's check in with the audience to see if they think they're going to backslide or not. So real quick question, because obviously telemedicine, virtual care has been a key piece of us addressing, and Central Maine's had a great example. Go into the chat box and answer, yes, our members are extremely satisfied, our providers are satisfied, and yes, we'll continue. Probably not. Our patients would rather come in and have a one-site visit once they feel safe. Maybe our clinicians really just don't like doing telehealth. They're used to the old way, and they feel there's value there, or we've not decided. We're waiting to see how things, no pun intended, pan out. So, David, where do you think the future lies for Jefferson?
Well, I'm pretty confident that we're going to use this technology much more broadly, and I'm hoping we'll use it to, as we were discussing earlier, engage with patients across the whole continuum, and especially use it as a tool to reduce disparities in care.
Jason, what do you think?
Well, it's interesting. 5 months ago, I was trying to talk to our medical staff about using teleneuro in the hospital, and wasn't received particularly well. Now, post-COVID, I was talking with our chief of emergency medicine, who was working in a critical access hospital ED, which was empty, and he was using telehealth to help his colleagues out at the Central Maine Medical Center ED, which was getting overwhelmed and doing clinical screening exams. And he was the one, he was the most dissatisfied before with, oh no, we can't do teleneuro. So I think we've hit on something here that we should be able to move forward.
Well, let's check in with our audience and see what the poll results are. We could bring those up. I think they are about done. And here we go. Wow, interesting. Either people are undecided or they're very satisfied and going to move forward. Not too surprising, I think. Awesome. Well, let's address this really important issue, I think, of what we've experienced, which is, there we go, that there may be a silver lining outcome to this pandemic, right? We may have some positive outcomes from these things that we've never thought about before. I want to comment, there's another response just came in on the chat box. Great panel. I'd love to hear more discussion about the need for research at every level, at every hospital, about how to become better learning organizations. So how do we, I knew you'd love that, David. How do we,
yeah, well, that's good. Yeah, let's hire this person, sure. Well, look, the learning organization, what a great concept now. This has been around for 15 years. Peter Senge, what a brilliant insight he had. To me, it's applying the tenets of performance improvement, because it's really the PDSA cycle, closing the feedback loop. That's a learning organization. Another perspective I would have, and let's see if we can connect the dots very quickly watching the time. So a silver lining that came out of this, I think, is the culture of the Incident Command Center. The Incident Command Center would, mandated for accreditation purposes, dust it off, pull out the loose leaf binder and, put it into action. It's way more than that. I think the Incident Command culture is daily huddle, closure of the feedback loop, awareness of going against the authority gradient as a necessary thing to improve outcome, and adhering to a changing clinical environment using a protocol or a guideline. Well, that's the textbook of performance improvement. So the silver lining to Quality Geeks is, wow, applying the incident command culture to the daily life moving forward. And lots of smart people are articulating this, Paul Barish, John Gleason, Bob Wachter, and others. There's a real opportunity here, perhaps even a quality tipping point as a silver lining outcome of what's going on. And sure, virtual care is a component, but I'm discussing the cultural silver lining that I think astute quality observers are noting at this opportunity.
Yeah, it's great you say that. I mean, we had that same experience with our incident command, to the point that I think when we decided to slow it down as things tailed off here from a COVID standpoint, it left a real gap. Yes. I think people had gotten so used to being able to, I've got a problem, the right group's in the room, we assess it, we put it in place, we come back, done, bang, good.
What I'm worried about, Jason, is a lot of places are going to say, okay, let's put that loose leaf back on the shelf, Oh gosh, I hope not. So I think that's the silver lining. But David Nace, I got two silver linings of my own. My 1-year-old grandson moved from Washington, D.C. to Philadelphia, and with one daughter, and my other daughter just got engaged. I don't think any of this would have happened without the pandemic. So there's your silver lining right there.
That's awesome. You know, it sounds like lots of people, this is, by the way, I am getting so many responses that say what a great panel this has been. And, you know, there's a lot of questions about virtual care, mobile care, telehealth. I've got responses here from 2 different people saying they're a payer and they are all in for doing this. How do we do it?
Wow.
And just incredible responses. I've not seen so many responses in such a webinar.
Great.
So I would like to bring that back, David. I know you and I, as an advisor to Innovaccer, we talk about this. Jason, you've begun to experience some of this. You know, part of our data platform at Innovaccer is really, how do you use data? How do you bring data in from everywhere, from the community, from pharmacies, from every single EMR that's out there, from the health plans that pay? They have such information that the community doesn't have, and certainly that the health system may or may not have. And then bring together all the physicians, all the specialists. People don't always stay at the same practice or system, and unify that into a patient record, and then allow that to activate it while people are working. The patient, while I have a hand phone, if I'm in an EMR, regardless of EMR, if I'm a care coordinator, and center care around the patient, or allow us to care as one. David, I know this really resonates with you. And
Well, yeah, I love this diagram, and Jason can speak to the operationalization of it all. I just love how it all ties together, and it's the vision, you know, it's the vision for the future. You know, once again, at my stage, I want to be around to see the vision implemented. And that's why I'm so excited to be working with David Nace and the Innovaccer team, and great leaders like Glenn Steele and Steve Klasko and others, because we all share the vision that this is it right here. Imagine, you know, one screen. How cool is that? That brings all this together. So every organization like Jason's that makes these steps in the right direction, it actualizes the vision. And we get information out of the data. That's the take home.
It's data and operations. That's how you succeed in providing health. Data and operations. The people, we deal with inherently smart people in our organizations and are capable and want to do the right thing. Data and operations. That's the challenge at every organization that I've been at to achieve in providing health.
And as I mentioned before, the idea of innovation, like a data platform, was built to innovate on. And as you saw that with the pandemic at Central Maine, the ability to build applications on your data on a dime and then deploy them. You know, I have to say, Jason, I can't really announce it quite yet, but one of the organizations that you've been at, you know, was dealing with COVID, and you know, they said, geez, our staffing system, like where the people that can intubate are, our supply system, you know, where our testing is, the information in the EMR, what beds are available, intensive care beds in particular. We can't get all this information tied together in real time. So we quickly stood up a management using this sort of innovation very quickly for a very large health system. So this is the sort of innovation we need in the future. And I think from the responses I'm seeing here, people are very excited about this webinar and your participation. So I'd like to say that I've answered many of the questions pouring in along the way, but I would like the opportunity to thank both of you for participating in this. That was a great panel.
Thanks for having me. It was great.
And David, thanks as usual.
Great to be together.
Great, and thank you all for the audience. You know, we had a great audience, tons of comments and kudos pouring in. Great questions. Sorry we couldn't get them to all. We will send out some information for those and who participated, and also give you a copy of the slide deck as well. So once again, David, Jason, thank you so much, and to the audience.
Thank you.
Bye-bye now.
That concludes the webinar.